Hello, my name is Dr. Carol Schall, and I'm the Director of Technical Assistance for the Virginia Commonwealth University Autism Center for Excellence. Today, I'm going to be talking about the changes in the diagnostic criteria for autism spectrum disorder from the Diagnostic and Statistical Manual on Mental Disorders, 5th edition. We refer to this as the DSM-5. This particular edition has had much controversy surrounding it regarding these changes, and today we hope to provide you with information so you can learn more about the changes related to the definition of autism in this Diagnostic and Statistical Manual. First, I'd like to review why autism is such a big deal. In fact, so often when kids go to school and they have an autism spectrum disorder, they frequently appear at the door and look like they're carrying this lunch with the tag autism right on the front of it. In fact, it is difficult frequently to figure out how best to support an individual with autism in a public school setting. Our goal is to figure out what that child needs, regardless of what the label is, and to provide them with the very best educational services we can. In order to do that, though, we do need to understand a little bit more about the child and their needs. To that end, the diagnosis of autism can be helpful to the school teams who are trying to meet those child's needs. Autism is also such a big deal because it has increased greatly over the last 20 or so years. In fact, in 1990, the reported incidence of autism was at about 1 in 4 to 5,000 children. Today, that incidence is significantly higher and represents slightly over 1% of the childhood population of children going to school today. As we look at the incidence of autism, we have to ask the question, why is that increase occurring? And there are some factors that have influenced the increase in autism. In fact, there's no doubt that there is an increased awareness of the disorder. 15, 20 years ago, when I started working with individuals with autism, when I described my job to others, they would frequently say, as I said, I'm working with autistic children, they would think that I was leaving out the R, maybe that I came from New York. And they would ask me if I'd like to paint or draw, thinking that I really meant to say artistic children. In fact, what's happened since that time is that we see that almost everyone knows about autism. Almost everyone that we interact with is aware of the disorder. When I meet people now and say that I work with children with autism, if they happen to be parents of young children, that frequently means that they ask me questions about whether or not their child has autism. Everyone is worried about this disorder, and they're even more worried about possible causes. That would be a discussion for another webcast. Returning to our slide, the other issue that has occurred during this time is what we refer to as diagnostic substitution. That is, that children who might have 20 or 30 years ago been diagnosed as having an intellectual disability are today more rightfully diagnosed as having an autism spectrum disorder. And so that could account for some of the increase. Finally, when the DSM, the Diagnostic and Statistical Manual of Mental Disorders, 4th edition came out, they added the idea of Asperger's disorder. Asperger's disorder refers to a different end of this spectrum of autism. In fact, prior to DSM-4, we only understood more classic forms of autism, whereas today we talk about autism in the context of a spectrum. The question, though, is there an epidemic of autism, remains unanswered. Scientists believe that the majority of the increase can be attributed to the first 3 factors that we just discussed. That is, increased awareness, so we're recognizing more mild forms of the disorder, diagnostic substitution, and widening the spectrum. However, it's possible that there is more autism when we look at the children that we're serving today compared to the children that we might have served 20 or 30 years ago. This question, however, is very difficult to answer using a research methodology because we don't have time machines. We can't go back to 1980 and use today's criteria to diagnose children who might have qualified for services then. Nevertheless, autism, because of its increased frequency, is in fact a public health concern from the perspective of meeting the needs of individuals with disabilities. I don't mean that this is an epidemic in the sense that someone can catch autism. You cannot catch autism like you might catch a cold or the flu. But we as individuals who serve children have to be aware of this increased incidence of autism, and we have to develop school programs that will meet the needs of this very specialized group. In fact, the whole point of discussing a label or a diagnosis for a child is to ensure that they receive appropriate educational services. When we're talking about autism, that really means that we understand the child and their unique needs very well, so that when we make educational decisions and plan for their educational program, we're making those decisions and developing those plans with the child in mind. So the DSM-5 is here. The DSM-5 was published and released in May of 2013. You can look at the website dsm5.org to see more information about the Diagnostic and Statistical Manual. In fact, as you go to that website, you will see that they have a PDF describing their changes to the Autism Spectrum Disorder label and how that might impact individuals. At this point, we frankly don't know. The actual impact of the changes in the DSM-5 have yet to be realized because we don't have enough practice in using it in a clinical setting and in an educational setting. And so at this point, we don't know, frankly, what the changes will be. We can speculate, but for right now, what we do know is understanding those changes will help us meet the needs of children. To further describe the differences between the Diagnostic and Statistical Manual 4th edition text revision, which is on the left-hand side of your screen, and the Diagnostic and Statistical Manual of Mental Disorders 5th edition, which is on the right side of your screen, we need to first recognize that there was a change in the way symptoms were described. In the DSM-4 text revision, or TR, on the left side of your screen, you can see that there were 3 key symptom patterns. And children, in order to qualify for the diagnosis of autism under this Diagnostic and Statistical Manual system, had to meet characteristics in each of those 3 symptom categories or symptom patterns. In the DSM-5, the committee decided to combine communication and social interaction into one category, specifically social communication. And so the first major change that we see is the move from 3 symptom categories to 2. In addition, there was an expansion of the behavior category in the DSM-5 to include sensory disorders. The changes in the total DSM system are summarized on this slide. Most specifically, the disorder known as Rets Disorder, which is a genetic disorder that can be diagnosed with a blood test, has been removed from the Diagnostic and Statistical Manual system. The reason for that is that the Diagnostic and Statistical Manual identifies psychological, behavioral, and emotional problems. It does not list medical diagnoses. Given the fact that Rets disorder can be identified with a blood test, it is not considered a mental disorder per se. It is in fact a genetic disorder. There's no doubt that there are genetic syndromes in the DSM-5, but the DSM-5 is seeking to describe the behavioral patterns of disorders and syndromes that might impact people. Secondly, there's been a major change in the diagnoses under Autism Spectrum Disorder. In the DSM-4, the category under which someone might be diagnosed with autism was termed pervasive developmental disorder. And that category included 5 disorders. Among those were Rets disorder, which we just discussed. Then we saw pervasive developmental disorder, not otherwise specified, Asperger's disorder, and childhood disintegrative disorder. All of these now are just simply termed Autism Spectrum Disorder. In a few moments, we'll review how we might characterize the different types of autism within the DSM system as it's now presented in DSM-5. However, what we do see is that instead of having 5 distinct disorders, we now have one disorder called Autism Spectrum Disorder with an array of categories of symptoms, an array of potential impacts of those symptoms on the individual who's being diagnosed. As I mentioned earlier, 3 symptom categories become 2 when social interaction and communication are merged to become social communication. In fact, there is some logic behind this change. When someone says hello to another individual, they are clearly using both communication and social interaction. In many cases, it's very difficult to separate those two and make them individual. Certainly, if I were sitting in a room by myself, talking to myself, I would be communicating without socially interacting. But then again, I might need services myself. Finally, the DSM-5, and I think a very positive move, added unusual sensory behavior to the criteria for autism, and we will review that in just a moment. On this slide, what you see are the specific criteria under each of the 2 symptom categories. And so let's first discuss social communication. In order for a child with autism to qualify for the autism diagnosis, they have to meet all 3 criteria under the social communication symptom category. In the social reciprocity characteristic area, this symptom pattern ranges from a total lack of initiation of social interaction, where an individual might show those very classic signs of autism where they refuse to even acknowledge or interact with someone else, all the way to individuals who have extreme difficulty engaging in normal back and forth conversation. And so when you look at this category of symptoms really captures what we mean when we talk about spectrum. Autism is a spectrum, meaning that individuals with autism might not be like each other. We might have an individual with autism who talks an awful lot, but has difficulty listening or engaging in meaningful conversation. Likewise, we might meet an individual with autism who doesn't engage in much conversation or even seek to interact with others altogether. In fact, just recently I was in a meeting with a young man who kept just simply walking out of the meeting because he didn't want to interact with the people in the meeting. And so we see this idea of a spectrum, meaning that some individuals have very significant impacts as a result of autism and refuse social interaction altogether, while others might seek social interaction but have extreme difficulty engaging in that smoothly. The next category of symptoms in this social communication category is nonverbal communication. And again, we see a range from those who use no nonverbal communication or lack facial expression, all the way to those who have difficulty integrating eye contact, communication, and gaze to indicate what the meaning of what they're talking about. So this again represents the spectrum, where we see individuals who have extreme difficulty with nonverbal communication and fail to use facial expression whatsoever, to those who have poorly integrated nonverbal communication and might smile long after a joke is told, or might look sad long after they hear disappointing news. Finally, we see that individuals with autism have difficulty and deficits when developing and maintaining relationships, specifically relationships with their age-referenced peers. We again see the difficulties ranging from those who appear to have no interest in interacting with people whatsoever or making friendships, to those who have difficulty adjusting their behavior to suit the situations. Some individuals appear younger than they actually are by age, just by virtue of not really knowing what's expected in certain social characteristics and in certain social settings. Under the second category of characteristics, restricted repetitive behavior, individuals with autism must meet 2 of the 4 criteria. In this area, the very first criteria is repetitive speech. And this also includes motor movements or repetitive or stereotyped use of objects. This could be simple motor movements such as flapping hands or pacing, to stereotypies that might include consistently locking and unlocking doors, or touching a chair 3 times, or twirling while I walk. This could also include echolalia, or repetitive use of objects. It also finally includes idiosyncratic phrases. One of the young men that I worked with years and years and years ago would frequently sing Sesame Street songs, but interestingly, he would sing them at just the right moment. And so he picked up a bluebird once that he was playing with in a group of toys. He was a young man below the age of 7. And he put that bluebird on his shoulders and sang, "Here's Mr. Bluebird on my shoulder." Well, he was trying to play with the bird, didn't understand how to play, and so he used this idiosyncratic phrase to characterize what was happening. We also see in the second set of characteristics an excessive adherence to routines, ritualized patterns of verbal or nonverbal behavior, or an excessive resistance to change. These routines really frequently act as a barrier to the person being fully included and fully able to be successful in their everyday activities. Next, we see highly restricted and fixated interests that are abnormal in intensity or focus. For example, some individuals with autism have an inordinate affection for example, information about trains. I once met a first grader who could tell me all about the train system in Italy, although he had never been to Italy. His interests meant that everything he talked about, everything he dreamed about, every time he had free time in school, he was drawing Italian trains, he was drawing maps of Italian train lines, he was listing the names of the lines. It was such a restricted interest that he knew everything there was to know about the Italian train system. Now, given the fact that he lived in Virginia, that was not very functional knowledge. He would never, in Virginia, take an Italian train anywhere. And so this interest was really restricted and did not translate into any real functional activity or any real vocational activity. Finally, as I mentioned earlier, this is the symptom pattern where we see the hypo or hyperreactivity to sensory input. This includes an apparent indifference to pain, heat, or cold. Some parents will talk about their children with autism and how they'll walk out on a 0-degree day without a jacket and not appear to show any pain whatsoever, or even notice that it's a little chilly. We also see an adverse response to certain sounds, textures, excessive smelling of objects or items, excessive touching of objects or items, and fascination with lights. This is the first time that we've seen this set of symptoms included in the Autism Spectrum Diagnostic array. And I think it's important to note that it has been long known that individuals with autism do have differences as it relates to their sensory interaction and the sensory input that they receive. And so now including this as a symptom category, it doesn't mean that every child with autism has to display this. Remember, in this B category, individuals with autism only have to meet 2 of the 4 criteria. It's an important point to note that the history of the child's diagnosis plays a very important role in any current diagnostic findings. As we understand autism right now, the majority of people have this disorder for their lifetime. And so if a child demonstrated the most salient characteristics of autism at the age of 4, but now as a 12-year-old are not demonstrating those characteristics as much, clinicians can feel comfortable in saying that the child still has autism. Autism doesn't go away. The symptoms and the patterns of symptoms may ebb and flow. And in fact, children do frequently show that they are able to cope with changes over time. And they may have learned behaviors. For example, an individual who maybe is late to talk may in fact learn to use words very effectively, but it's almost like they're using the words as if they're fill in the blank. One young man that I met would, whenever he was asking a question, would always start it with the phrase, "May I please?" And then he would ask for the thing by saying, may I please have blank, please. So for example, he would say something like, may I please have lights off, please, instead of saying, would you please turn off the lights? Every single question that he had was always phrased that way. May I please have blank, please? May I please have quiet, please? May I please have hug, please? May I please have, you can fill in that blank forever. That's how he asked every question. Now, he had learned to ask questions, and so he might not have showed the degree of severity that he did previously, but there was no doubt that he still had autism. And so again, clinicians can rest assured that if there is a history of autism in the child's diagnoses, that they can continue to use that history as a current diagnostic finding. The final criteria that must be met in order for an individual to qualify for an autism spectrum disorder are on the slide before you right now. The first criteria here under letter C is important to note. That is, symptoms must be present in the early developmental period. In previous editions of the DSM system, that usually had an age, prior to age 3. Well, there is no longer an age noted. However, it is important to note that an individual may demonstrate those symptoms early on, but those symptoms may not be fully manifest until the social requirements or the social demands exceed their capacity to display them. For example, consider the preschooler who's having difficulty in preschool, and everyone thinks, well, that's just him, he's just a little lagging in terms of his social skills. By the time he gets to 3rd grade, if he's still showing those difficulties, and if he's showing all of the other symptom categories in the autism spectrum disorder category, he may in fact have an autism spectrum disorder. The diagnosis may not occur until 3rd grade, but the symptoms were present when he was much younger, in the toddler age. It's important to note that the symptoms cause a clinically significant impairment in the person's life. This means that although you're listening to this today, you may be thinking to yourself, I have those characteristics, I think I may have autism. Unless there is a clinical significant challenge that you face in relationship to maintaining relationships with others, maintaining a job or going to school successfully, or organizing your life so that you can cope with changes in your life, you probably don't have autism. Some people have asked me, do I think Bill Gates has autism? Frankly, I don't know. I don't know Bill Gates, so I don't have an opinion one way or the other. I do know, however, that he's doing pretty well. He's got a lot of money, certainly a lot more money than I do, and so if he does have autism, he clearly has learned to cope quite effectively with it. In fact, you might argue that that may not be a clinically significant impact. Finally, it's important to say that a child has autism if the symptoms that they are displaying are not better explained by intellectual disability or global developmental delay. The one exception here is when there is a comorbidity of intellectual disability. Comorbidity simply means having 2 co-occurring diagnoses at the same time. In fact, it's frequently the case that individuals with autism have co-occurring diagnoses. So, if an individual who has an intellectual disability but is actually communicating or interacting with others at a lower rate than as indicated by their abilities with their intellectual disability, in fact, they may also have autism as well. I think where this is most difficult to sort is when we have individuals who have very, very significant intellectual, developmental, and multiple disabilities. It may be difficult to sort out what is autism and what is the significant disabilities that the individual is facing. There's one more, I think, most important change to the DSM-5 system that did not exist in any prior DSM. That is that now, instead of identifying someone as having Asperger's disorder or pervasive developmental disorder not otherwise specified, you would, as a clinician or you as a parent, may hear about children referred to as requiring support, or level 1, requiring substantial support, level 2, or requiring very substantial support, level 3. In each of these areas, individuals could, for example, require support when it comes to social communication, but require very substantial support when it comes to restrictive and repetitive behaviors. There is a lot of detail in the DSM-5 that describes each of these categories, and they range from, at level 1 as it relates to social communication, individuals who have a social communication deficit when supports are not in place, all the way to individuals who have severe impairments related to social communication. And so by being able to note the level of support required, clinicians and families can begin to talk meaningfully about the types of programming and the types of supports that an individual might need in their educational and future programming. As it relates to restricted repetitive behavior, we see that same range. Individuals who might be at level 1 and require some support might have some inflexibility of behavior. That inflexibility might cause significant interference with functioning in one or more contexts. The range goes all the way to the level 3, where there are extreme difficulties coping with change, coping with demands to restrict repetitive behavior, and marked interfering in all spheres. So again, we see the range from these symptoms interfering with the person's life in a couple of settings to all settings causing significant disruption. Again, by being able to note the types of support that the individual requires, the team can begin to really decide how best to support that individual in educational programming. There's also a new diagnosis in the DSM-5 that was not there prior. This diagnosis is referred to as social pragmatic communication disorder. Not much is known about this, but this would be a diagnosis that might account for those individuals who have significant impacts in social communication, but do not evidence repetitive and restrictive behaviors. And so I just mention it because it may have an impact on the number of children who might in the future be identified with an ASD, particularly those individuals who have more mild patterns of interaction with others. I think it's important in the context of this lecture to take a moment to talk about medical diagnosis versus educational eligibility. In fact, these two frequently are serving different purposes. When a doctor, a psychiatrist, or a psychologist evaluates a child for autism spectrum disorder, their question is, what is the disorder that is present that best explains the trouble that the child is having in all contexts in their life? That medical diagnosis then becomes a label. In the educational world, however, school psychologists, educational diagnosticians, and educational teams don't diagnose children. Instead, the role of the educational team is to determine whether or not a child has a disability that interferes with their ability to learn. And so the question is not one of diagnosis, but one of eligibility criteria. Does a child meet the criteria to be considered a person with a disability under the Individuals with Disabilities Education Act? Those are two different processes, and yet they're often confused. Families often think that when they're sitting down with the school team, that the school team is in charge of diagnosing the child in school. That's not the case. Likewise, doctors often think that just by virtue of giving a child a diagnosis, that means that that child should now receive services from the educational system. Again, that's not necessarily the case. In order for a child to receive services under the Individuals with Disabilities Education Act, they must be found eligible by meeting the requirements of 13 different categories or labels. So as we look at how does the DSM-5 impact educational eligibility, the first area we might look to is alignment. In the previous edition of the DSM-4, what we saw was that the category was pervasive developmental disorder, pervasive developmental disorder. And so the educational category in the Individuals with Disabilities Education Act was termed autism. Some school divisions interpreted that term autism very, very strictly, saying that only a person who actually has the diagnosis, the actual diagnosis of autism, could be served under that category under IDEA. And yet, many individuals have other forms of the disorder under the DSM-4 system. They might have had the label of Asperger's disorder or pervasive developmental disorder not otherwise specified. They could also be served under the category of autism in the educational system. By having one category now, Autism Spectrum Disorders, in the DSM-5, and one category, autism, in the Individuals with Disabilities Education Act, we may see an alignment of those two different ways of viewing the needs of a child. It's also to note that historical diagnoses plays a role in the DSM-5 system. And so if a child was found to be a child with autism at the age of 3, and they continued to have autism or display the symptoms of autism at the age of 6, 9, and 12, because of that history, there is no reason at the age of 15 at one of the triennial eligibility determination hearings to really revise that diagnosis. The question is not what label does the child have, but what services would give that child the free and appropriate public education that they have a right to. Finally, the DSM-5 is meant to increase the specificity of the autism diagnosis. Eventually, that increased specificity will assist educational teams in meeting the needs of individuals with autism. Currently, however, the DSM-5 really is not going to have much impact on the educational system. The reason for this is that the definition of autism in the Individuals with Disabilities Education Act is set in the law itself. So the DSM-5 has not changed the law. Only a literal act of Congress would change the law to reflect a new definition for autism. So at this point, the DSM-5 does not really play a role in determining eligibility in terms of a child's needs in the school system. The Individuals with Disabilities Education Act does that. At the same time, it's important to note that for those educational and psychological diagnosticians, that there are no tools currently calibrated to the DSM-5 criteria. The tools that we currently have that we use to screen or identify children with autism were all developed under the auspices and the requirements of the DSM-4 system. And so again, as we look at how do we best serve children with autism in our current context, DSM-5 is not really going to have that much of an impact at this point. Here are a number of different tools that individuals have frequently used to identify autism. And as I mentioned, all of these are based on the DSM-4 system. There are other critical areas that need assessment when serving a child with autism. If a child with autism has a functional behavior problem, then we need a functional behavior assessment or an FBA. Person-centered planning is critical, particularly as that child moves from childhood to adolescence to adulthood. We need to teach individuals with autism how to make choices about their futures and their careers. We also need to keep an eye on functional program planning. That is, can individuals with autism, as they graduate from high school, communicate, cross the street, drive a car, use an ATM machine, access services in the community? Can they take advantage of recreation in the community? Those everyday functional skills are significantly impacted in this disorder. And so it's important not just to understand a child's reading level, but how that child uses reading in their everyday lives and their community to access information. And finally, it's absolutely critical to consider academic assessment and curriculum planning. As we think about assessment and eligibility, we should not think that our job is done once we know what a child has, because no child with autism is alike. No individual can have the same program as any other individual. This is a symptom pattern of behaviors. This is not like an infection where if you just get the right antibiotic, you'll be cured. Instead, these are patterns of behaviors that we tend to shape over time to be more functional in the context in which the child lives, goes to school, and interacts with others. What I'm really saying is that when we consider a child or an adolescent in our current school system, we have to remember that that child's life is comprised of their academic needs. They have intense social needs. In fact, as the parent of a 15-year-old without a disability, I can attest that the social needs are sometimes more important than their academic needs. They have their family and their family's needs to meet that child and to help that child grow and become the productive citizen that they dream. They have their own behavioral needs as it relates to how to cope with the world and how to get along with others. There's no doubt that every human has physical needs, including children with autism. And so as we think about that child, we must remember their physical needs. And finally, we're doing all of this work in school so that children leave us with a happy and a hopeful future. And so we have to consider their future needs. When you think about the child in terms of their needs and in terms of the supports that will help them advance in school, the label is the smallest thing that we would be talking about in a meeting. The most important things to be talking about are the rest of the circles on the slide right now. So more important than the tools or the diagnosis or the label are the questions that we attempt to answer as we come together as team members to meet a child's educational, social, and future needs. And so I have a number of questions on the slides that follow, such as, what should the teachers supporting this student do to ensure that student's academic success? In fact, that's a much more critical question than what label should we put on a student. When we know that a student has a label, that's really all we know. We don't know what to do. But if we understand what teachers should do to help this child learn, that's a much more valuable use of our precious time as we're meeting to discuss how best to help a child. We also have to think about classroom supports, accommodations and modifications that may assist that student in learning, the curriculum needs that the student demonstrates, related services related to physical therapy, speech therapy, or occupational therapy, long-term projections in terms of the child's academic career, especially as it relates to post-secondary education and career planning, and then supports and services that will result in the greatest independence and achievement. When you consider those questions, again, diagnostic labels are the smallest part of that discussion. If you're trying to figure out how best to guide a child toward a future where they work, live, and play in their home communities, knowing that a child has autism doesn't really help you figure out what to do. But because of the way the Individuals with Disabilities Education Act is written, labels are the gateway. And so it's almost like this snakes and ladders game, where some years you move up and some years you fall down. In order to even get in the door, you frequently need that ASD label so that you qualify for services, so that you hit more of the ladders than you do the snakes. There are some complications related to autism spectrum disorder and educational eligibility. Specifically, the educational category versus the DSM. The DSM really is a psychological, mental health, or medical diagnostic manual. And so when we look at that DSM category, we will still see individuals who have those older diagnoses. We will still see individuals who have a diagnosis of PDD-NOS, or an individual who has a diagnosis of Asperger's. We really have to be aware of that and understand that today we would use the term autism spectrum autism spectrum disorder. We have to be aware of comorbidities, that while a child has autism, they may also have other disabilities that impact their ability to be fully included and access the general education curriculum. So, for example, an individual who has autism and an intellectual disability has dual needs that need to be met. Another individual who has autism and is also gifted has a number of needs that need to be met. We have to consider the family's history and their ability to advocate for their child and meet their child's needs at homes. And then finally, we have to consider those secondary characteristics, which include interfering behaviors and mental health diagnoses that may complicate the life of the individual with autism. I have a number of points on this slide that I want to make by noting that these are true or false. Previously, I had these animated to show whether they were true or false, but we ran into some technical glitches. So forgive me while I read through these and note which ones are true and which ones are false. The first one, only a medical doctor can identify a child with an ASD. This is false. If a school team comes together and says that a child, regardless of what their medical diagnosis is, qualifies for the Individuals with Disabilities Education Act for an individualized education plan as a child with autism, they are fully empowered to do that. Autism is included in the IDEA array of possible disabilities, and school psychologists are trained and empowered to identify children as eligible under that category. The next statement, the only way to identify a child with ASD is to give an ADOS, or an Autism Diagnostic Observation Schedule. This is also false. Sometimes children already come in when being identified as a child with autism. Other times it's just very clear to the team that this is what the child has, and so there's no need to use an ADOS. The ADOS does not necessarily point you toward educational supports or what to do to assist a child to learn to read. It can clarify the important aspects of the diagnosis that might help you understand the child, but it may not help you understand how best to educate a child. All students with ASD need an ADOS, that is an Autism Diagnostic Observation Schedule, at every eligibility to maintain the label. This is also false. The requirements for repeated triennial eligibility meetings and eligibility assessments are contained in the Individuals with Disabilities Education Act and are not determined by disability. Instead, they're determined by the eligibility team that would frequently start with questions and then use assessments to assist them to answer those questions. The ADOS, or the Autism Diagnostic Observation Schedule, is the gold standard in autism diagnosis. This is true. At this point in our history, this is the best tool to identify a child with autism. It is better to wait till a young child is 8 or 9 before talking about autism. This is false. The best time for us to identify and then intervene for a child with autism is before the age of 2, if we can, certainly by the age of 3. We actually have tools that assist us in making those diagnoses and determinations early on, and we are most effective when we can provide early intervention between the ages of 3 and 6. In fact, this gets to the final point on this slide, that some have said to me that autism is too stigmatizing a label for a child under the age of 5. This is false. What is stigmatizing is when a 4-year-old is playing in the sandbox, repeatedly letting the sand fall through their fingers, and another child comes over to play with them, and that 4-year-old runs screaming from the other child for fear of social interaction. That is far more stigmatizing than any report any psychologist would ever make. We empower parents, educational teams, and care providers and support providers when we identify children with disabilities and develop plans to meet their needs. The next point on the next slide, Asperger's disorder is really an emotional disturbance. Again, this is false. If you still have children who are being identified as having Asperger's disorder, or if you currently have children who were previously identified with Asperger's disorder, they qualify under autism spectrum disorders better than they do under any other disability. It doesn't really matter, the next point, what label a child has as long as the child gets appropriate services. This one is basically true. No doubt the label can help a family become empowered and connect with support. There's no doubt that the label can help the team understand the child. And so to that end, a label may be helpful. But what's more helpful is understanding the child themselves. I've frequently said to parents, you don't want an expert in autism, you want an expert in your child. And that is worth far more than knowledge in autism. Final point on this slide, there are too many children with autism in our school system, so we should stop identifying them as such. This is controversial because, in fact, if a child has autism, whether you identify them or not doesn't change the circumstances of their needs or the characteristics that they display in school. So if you call them something else, they're still there. They still have the needs that they came to school with that morning. Parents just want this label for the benefits that they get. Now, while I will acknowledge that there are some parents who see labels as an opportunity to access public benefits, by and large, this is a false statement. Most families would be far happier to have children who are able to fully participate in life and become independent, contributing members to society. In fact, that's what all parents of children with autism want for their children, to have the most independent life where they can contribute and find their own corner of the sky. And so parents don't typically want a diagnosis. Instead, frequently what parents want is helping their child to become more independent. The next two statements on this slide are counterbalanced. One says autism is overdiagnosed. The other says autism is underdiagnosed. And so one or the other of those is true. Well, I will tell you that it is not overdiagnosis at this point, according to science. That's not to say that there may be places where there are doctors who might influence the diagnosis of autism in a particular rural area. That is to say, however, that by far when we look at the epidemiological data that's available to us, autism is frequently underdiagnosed. That is, we frequently find more children who have the diagnoses but were not diagnosed than we do find children who were diagnosed with the diagnoses but don't have it. It is true also that the current incidence of ASD is still 1 in 88. There have been other studies that have used other methodologies and have suggested that autism may be as frequent as 1 in 50. But those studies were based on parent telephone surveys. They were not epidemiologically designed. And so the current best estimate of the incidence of autism in the United States today is 1 in every 88 children. That's why I say it's slightly more than 1%. It's about 1.18% of children right now. The next statement is, all students with ASD need 40 hours a week of intensive applied behavior analysis. This is false. In fact, there was a study recently completed by the researchers at the University of Chapel Hill in North Carolina, the University of North Carolina, Chapel Hill, excuse me, who found that using ABA or a structured, well-designed classroom made no difference in the outcomes for children with autism. The final statement says we don't provide ABA in school, specifically public schools. And this is also false. ABA is not autism specific. ABA is not limited to 1 or 2 practices. ABA is used every day in every single environment. The room that I'm sitting in right now has a big red exit sign at the back. If that exit sign began to flash, and if I heard an alarm, that's using ABA to indicate to me that I need to change my behavior. The alarm has been conditioned so that I associate that with exiting the building. And so the exit sign with the alarms attached to them are actually a form of ABA. So ABA is used everywhere in every environment. And even public school teachers can implement ABA and use it very effectively to meet the needs of children with autism. While we're talking about these final myths, I think it's important for us to know what is it that children with autism need. Because as I've been pointing out throughout this discussion, the real key to diagnosis is understanding a child's needs. And so let's talk about intensive family training and support for that child. When I meet with families after their child has been diagnosed with an autism spectrum disorder, I tell them that it's not 40 hours, it's not hiring very expensive therapists to come to their house. It boils down to 3 things that happen every hour for a child with autism. And they are interact with that child regularly to elicit communication. And usually the way this looks for very young children is to start a pattern of play. Maybe you're pushing the child on the swing, but every time you push them, you say the word swing, swing, swing. And then one time you catch that child, and once they've gotten used to that pattern, that routine of you pushing them, you hold them and you wait. A lot of times that child with autism will make a sound, usually kind of as close as they can get to the word swing. They might say ee or ing or ee. As long as that sound is not a whine or a cry, then say swing. That's how I teach parents to interact with their children, especially their very young children, to elicit communication. If an older child who has some words, maybe an older child is using one-word phrases, and they walk over and they say raisin, I might say, yes, it is a raisin and it's tasty. Would you like one? And then I might model, raisin please, or I want 2 raisins please. So I always teach parents to interact so that they're always eliciting new communication and more communication from their children. I want then parents to teach and reinforce new skills at home. This might be naming things, and so I ask parents to sit with their children with books, with toys, or even sitting at the dinner table and naming the fork and the knife and the spoon, or identifying the chicken and the peas and the carrots, or sitting with a book on the lap and pointing to the various characters. I want parents to sit with their children and help them gain new communication, new names for things, and most importantly, learn how to do things for themselves. This gets to the last one, which is increase independence. I want parents to always be working with their children so that they learn to do the things that they need to do. And so for very young children, that might be putting on their coat when it's time to go outside, taking their coat off when they come back inside, putting their shoes on, getting dressed in the morning, using the restroom, washing their hands, setting the table, clearing off the dishes from the table, throwing things in the garbage can, cleaning up after playing. These kind of everyday independent activities really help that child learn to cope with the environment. If parents of children with autism and teachers of children with autism focused on these 3 things, especially for the very young children, every hour, children with autism would surely get 40 hours of intervention and more. As we look at eligibility issues, though, we want to delve a little further into this whole diagnostic picture. And so, as you see on this slide, there are arrows that help you move through the various ways that you might encounter children with autism. The first one has a medical diagnosis. If a child comes to school and they already have a medical diagnosis, then the eligibility team should be asking themselves, what's the impact of that diagnosis in the educational environment? What supports does the child need, and what program would best meet that child's needs? So the questions that child study team asks and attempts to answer about that child should be geared around those and not necessarily around diagnoses. If a child enters school and they have not been diagnosed, but they present a clear, uncomplicated presentation of autism spectrum disorder, and everybody on the team looks at the child and says, yep, that's an autism spectrum disorder, then you need to assure that there's agreement between team members and that autism spectrum disorder impacts that child in the school system. Yet again, you're looking at the supports that the child needs and the program that would meet that child's needs. Sometimes children enter school and there's more than one disability. There might be 2 disabilities or more. You might have a child who's presenting who has a hearing impairment, but also is having extreme difficulty acquiring language and interacting with others. That child might have an autism spectrum disorder. And so when you see 2 or more disabilities, you have to ask yourself as an educational and eligibility team, which of these disorders has the greatest impact in the life of that child? And then how do we formulate supports to meet that child's entire needs, and what program would best meet their needs? Finally, some children come to school and it is a complicated picture. They might have an autism spectrum disorder, or there might be a number of other disorders that are impacting them. That's when you need a full multidisciplinary team, and you might even require outside consultation to assist you in best understanding the needs of that child and matching supports and programming to meet those child's needs. The state of Missouri has developed a 3-tiered approach, which I think is very helpful. And so there is a website at the bottom of this slide that you could review. The information on this slide was taken from page 12 of this portable document online. And this identifies how do we match standardized tools and potential tools that a clinician might use when they see a child that might have an autism spectrum disorder. And so they divided this into 3 tiers. The first tier refers to a child who has unambiguous autism spectrum disorder. Well, the clinician at their discretion would choose standardized tools and identify the tools that would best meet their needs and the team's needs as it relates to understanding that child. At the second tier, a child might have mild symptoms or more complex symptoms. And so that there might be difficulty figuring out, is there a differential diagnosis? Does the child have an intellectual disability? That clinician should use standardized tools to help them measure the degree to which that child is different from other children. They want to consult with the team and select instruments that really help them answer the pertinent questions. Those instruments could include some of the checklists that we looked at earlier in this lecture. Finally, the Missouri approach talks about Tier 3, and that is there are very subtle or complex symptoms, or there's a very complex history, and the team has multiple concerns. At that point, yes, the team should use standardized instruments, and the ADOS is usually needed as well as other tools to best understand that child. In closing, what we've talked about today is the impact of the changes in the Diagnostic and Statistical Manual, 5th edition, to the diagnosis of autism, and more specifically, to the educational team members who are attempting to meet the educational needs of those children in their public school systems. I have some closing points. Diagnosis is least important when we consider how do we best serve a child, so it doesn't make sense to argue about diagnosis. It makes a lot of sense to argue about what we should do to best support a child, what we should do to best meet the educational and functional needs of that child, and how we go about helping that child achieve the greatest independence that they can. And so our focus really should be on the support needs of the child. And any tools that we use to diagnose or understand a child's needs should help us answer the questions we have about that child rather than focusing exclusively on the diagnosis. Thank you again for tuning in to this webcast, and I hope you found it helpful.